Hi, so I'm Dr. Dangeban, the one who will teach you this at least first semester, anatomic pathology. I put in your team's group video introduction about me, about what's happening, which is the list of events during at least this first semester. I also put on that files in Teams for you the first chapter from the book of the department from which you need to learn for the exam. The other chapters will be also put in the moment when we start that particular new chapters. And I also put, for those who want to have more information, the last edition book of Robbins of Basics of Pathology, and also a much shorter but very good for student use rapid review of pathology, which is for short but exactly the essentials of the anatomic pathology. And now we are starting with the first lecture, a 2-hour lecture. We'll have in this week lecture also in place of practical labs. So this week we'll have 2 lectures, in fact. First, this one for the Monday morning, in the Monday morning, and the other, I believe it's in after 2 days. Anyhow, I am recording these lectures, so they are not live on Teams. So for this reason, you can visualize these lectures anytime you want, and I am not doing a presence for the lectures. Next week, when the practical labs will start, the practical labs will be live on Teams and with presence being made. So be aware about. For the moment, in the first semester, we are studying what is called general pathology, followed in the second semester by the systemic pathology. As you can see in this image put here, which is an image from Robbins, in fact, taken, general pathology, it's the link between all the preclinic disciplines like anatomy, immunology, genetics, embryology, histology, chemistry, biochemistry, and so, and make the link with the clinical disciplines that we will start to learn about them in the 4th year. And pathology in general, it's this link, but general pathology is the part of pathology who's studying general mechanisms and general disease who can affect any system, organ, or tissue in the body. And systemic pathology in the second semester will learn supplementary, because some diseases are studied in the first semester, so supplementary, but dedicated for each organ in part, for respiratory system, cardiovascular system, digestive system, and so and so. So this will be the second semester systemic pathology. In anatomic pathology, we learn, in fact, what is anatomic pathology, is how the lesions, the diseases, are looking at macroscopic and microscopic level. But pathology, as I already said in the introduction, in Western countries means also physiopathology. So, because here in Romania we have, at least in Cluj, not necessarily in entire Romania, we have this separation between physiopathology and anatomic pathology. We have, in fact, agreement with physiopathology to avoid, if as much as possible, overlaps of information getting from us and getting from them. And when we study about something, about a lesion or pathological lesion or a general or specific pathology, we are trying each time to start with a definition to define the condition. And after that, to at least say a few words about etiology, if it's known, the cause of the disease, and also a few words about the mechanism of production of those lesions. So we also are putting in our lecture some physiopathologic mechanisms, but they are not necessarily for exam. It's necessarily for understanding, but not for learning for exam. Anatomic pathology means almost only definition, macro and microscopy. At macroscopy, we in fact put descriptions about what we can see with naked eyes on surgical specimen or at autopsies. And microscopy, it's the one who make the final diagnosis, because at the end, our specialty, it's only a diagnostic specialty. We don't really treat patients, at least not the alive ones. We don't treat anything, we just put the diagnosis, and the clinicians are doing the rest. This is our job, and for this, microscopy is by far the most important part of the specialty, being responsible for more than 80% of our efforts. But for your purpose for this lecture, I will try to minimize the microscopical descriptions because they are hard to be retained, but still microscopy is a part from your necessary knowledge to pass anatomic pathology. In this general pathology, we will discuss about 4 major chapters. First of it, it's called fluid and hemodynamic disorders. Is the first and somehow the most easy one. The second chapter will be metabolic diseases, the third for the last one, tumors. This first chapter, we start with it, it's fluid hemodynamic disorders, and as part from this chapter, we'll study about hyperemia, about hemorrhages, about thrombosis, embolism, infarctions, shock and disseminated intravascular coagulation, and at the end about edema. And all this start with hyperemia. First of all, to understand what is hyperemia, I must make a sort of introduction in the subject, telling you that we have more than one fluid in our body, circulating in our body. And one of these fluids is the blood, which is a fluid circulating in inside blood vessels, which is moved, this fluid, by the pump, which is the heart. But it's a closed system, this vascular system. And it starts with artery, smaller and smaller and smaller, and it's ending with venous circulation. Between the arterial and venous circulation, we have the capillaries, which is the only part from this blood circulation who has the wall thin enough to be permeable for the fluids inside the blood to extravagate, to go out from the blood in the interstitium fluid. Because the second fluid that we have, it's the interstitial fluid, which is present in all tissue in smaller or larger quantity, depending from tissue to tissue, but all cells in our body are surrounded by interstitial fluid. And the cells, for their living and function, need to take food for energy, anabolic substances, and oxygen for respiration. All these substances are taken not directly from blood, but from the interstitial fluid. So the anabolic substances and the oxygen from arterial blood should extravagate from the blood in the interstitial fluid to be put on dispersal of these cells. And this is possible because the wall of capillary is very, very thin and permit this extravasation of fluid in outside. At the other end of this capillary circulation, because part of the fluid was out, the concentration of what remained in the blood in the capillary, in the lumina of the capillary, became higher and higher because it's loosed the liquid, the serum, with salts, with small proteic substances, with oxygen. Everything it's loosed out, and the concentration of the blood became higher, remaining large protein substances and obviously the cells of the blood, the red and white cells of the blood, in higher concentration. And for this reason, being a higher concentration in the blood, in the capillary, will have a resorption of the liquid from the interstitium back. So we have a permanent exchange between blood and interstitium. At the arterial end of the capillary, we have a leak out of fluids, and in the venous end of the capillaries, we have an absorption back of this fluid. When it's absorbed back, it's absorbed together again with dissolved catabolic substances resulting from metabolism of the cell, and also with carbon dioxide resulting from the respiration of the cell. So in this way, we have a circulation of fluid from blood to outside of the interstitial fluid and back. But it's always disequilibrium here in this exchange, meaning a little bit more fluid it's extravagating out than it's coming back. So it's a permanent excess of interstitial fluid, which need to be drained from the interstitial space. And this draining, it's made by the lymphatic system. So the lymphatics have this role to drain this excess of interstitial fluid, which is produced continuously because of leaking of fluids from the blood. So in fact, the lymph by itself is nothing else as a composition than the interstitial fluid, and it's added in the lymph. After entering this fluid in the lymph nodes, it's added obviously lymphocytes, which are produced here. But initially in the smallest lymphatic capillary, we have only interstitial fluid, calling it lymph. After this small introduction, we start to study about hyperemia. Hyper means higher level, higher quantity of emia, which is coming from the Greek hemia, which means blood. So by definition, hyperemia means an increase of quantity of blood in a particular region or organ of the circulatory tree in the capillaries. This hyperemia, it's divided, at least in our concept here in Cluj school, in two different pathological processes: in congestion, which is also called active hyperemia, and in stasis, which is also called passive hyperemia, because the mechanism of production is different. But in the Anglo-Saxon books of medicine, this difference is not made. So for them, English literature, hyperemia, it's equal with congestion and stasis, so all being put together and not making a real difference between them. Our concept here to make this separation is coming from German literature, and this is how traditionally we teach this subject by making this separation. And as I said, separation is made because the mechanism for congestion and stasis is different. By congestion, we understand that the increased quantity of blood in the capillaries is resulting after a dilatation of the precapillary arterial vessels, which has as a consequence increase of volume of blood entering in the capillary. So it's an active process because this dilatation, vasodilatation, arterial dilatation more exactly, it's resulting after active process of relaxation of the muscular wall of these arteries. The stasis will be detailed later about the mechanism which is producing it. In congestion, because we have a higher quantity of red arterial blood rich in oxygen accumulating in the certain territory of our body, that affected part, tissue or organ, will turn in red. And this reddish aspect, it's called erythema. We can have congestion in pathological conditions, but also in physiological situation. Not all congestion are pathological. For example, absolutely physiologically, during exercise, the muscle is producing and consuming much more energy than in relaxation period. For this more energy, it's consuming more oxygen. To have more oxygen, it's needed that at the site of this muscle to have arterial dilatation, giving more arterial blood with more oxygen at the site to assure this more necessarily in oxygen of the muscular cells. So during such an exercise in the muscle, we'll have physiologic congestion. Also, the same thing is happening in the gastrointestinal wall during digestion, because also digestion means excretion of enzymes, which is an active process consuming energy and oxygen, and also during the absorption from the lumina, intestinal lumina of nutrients. This process of absorption is an energetic process which needs more oxygen. So in the wall of the intestinal tract during digestion, we have also a physiologic congestion. The pathologic congestion, which is part of a much more complex reaction in our body called inflammation, we'll discuss in much more detail separately in the chapter discussing about inflammation, what it's really happening there. But for the moment, at least, to retain the idea that in all inflammation of any etiology, the first step which is happening before anything else is a local congestion. So at the site of an inflammation, we have much more blood, necessarily not only to bring more oxygen, but also to bring other protein like immune globulin, for example, necessarily to fight against an etiologic agent at the site of an inflammation. As a result of this congestion, the reddish erythema color, it's possible to be seen at any site which is accessible for naked eye to look. So the skin, the oral mucosa, turning in red in an acute pharyngitis, so it's an inflammation. Or at the level of the skin, an infection of the skin will turn in red, that affected area. Also other mucosa like the conjunctiva of the eye in conjunctivitis. These are the sites visible at outside, but we, at autopsy at least, we can see, and surgeons also can see inside the body, and the inside is happening the same thing. Here, for example, it's an image of one of my cases, a 2-year-old boy who died from an encephalitis, viral encephalitis. I am working as a pathologist in Children's Hospital, and for this reason, most, if not all, but most of my personal images which are illustrating the lecture are coming from children for this reason. Here at the surface of the brain, we have the arachnoid layer and pia mater layer covering the brain. Between them, it's a subarachnoid space in which we have the cerebral fluid present. All these layers, arachnoid, pia mater, and the cerebral fluid, are completely and perfectly transparent. So we can see through them. And in the subarachnoid space are also the surface vessels of the brain, which are visible normally for everybody. And these vessels, in this case of an encephalitis, are seen to be dilated and becoming visible even the smallest arteriolar vessel and maybe even capillaries because they are dilated and full with blood as a result of this congestion, leptomeningeal congestion. Because in the encephalitis is not only the brain affected but also the leptomeningeal layer of it. So we have here at the surface, seeing by transparence this congestion of each smallest vessels. Macroscopically, it's easy to imagine that if in an organ we have more blood than normal, this organ should be bigger and weightier, the weight being higher. If the organ have edges like the liver, these edges will become rounded, and such event is possible to be for the liver at least palpated by the clinician during clinical examination. Obviously, the reddish color it's possible to see only for the outside layers of the body, skin mucosas. But for us and surgeons, we can see the same thing inside the body. The affected by congestion area is also warmer because it's full with arterial blood which is coming from deep of the body. And in some location, not all, but in some location, this congestion can also generate a pulsatile pain, especially at the level of tooth in pulpitis. At microscopic level, it's not a big deal to be seen. In fact, we have dilated capillary full with blood, nothing else, which is an obvious result of this higher quantity of blood inside these capillary beds. Here in this image, we have the image of a lung with an inflammation, which is called pneumonia. And as a result of this inflammation, the alveolar wall have the capillaries dilated full with blood, which is very well seen here. The image is much more complex than just congestion because we have also an exudate of inflammatory cells inside the alveolar space. We have much more than just congestion because, as I said, congestion is only the first step of a much more complex reaction of the body, which is called inflammation. But at least for the moment, this is what is interesting for us, to see this dilated capillary in the wall of the alveolar space full with blood. In most situations, once the cause is removed, the congestion disappears without any consequence at all. If the etiology, the cause, is remaining for a long period of time, the congestion can evolve with some complications. For example, because it's long in duration, the quantity of liquid leaking from capillary in the interstitial fluid will be higher than normally. And the lymphatic drainage of this higher quantity of liquid will be exceeded. So the interstitial fluid is accumulating locally, and this is called an edema. If the congestion is even more longer in duration and more severe, the dilatation of the capillaries will make possible to appear gaps or holes, very small holes between endothelial cells. And in these gaps or holes between endothelial cells of a dilated capillary, some red blood cells can also extravagate outside in the interstitial space. And this extravagation of red blood cells outside from the blood vessel is called hemorrhage. They are very small, sometimes invisible macroscopically and only being visible microscopically, and for this reason they are called microhemorrhages. What is important to remain with the idea is the fact that at least in a congestion, the accumulating blood being rich in oxygen, being arterial blood, the local cells at least are not suffering from hypoxia. So they are affected by edema, by the microhemorrhages eventually, but they are not suffering from absence of oxygen or hypoxia, because it's plenty of oxygen at the site, and this oxygen, plenty of it at the site, it's also acting as a destroyer against microbes. Some microbes are not resistant to the presence of oxygen. So this is why it's one of the consequences of inflammation, this congestion, because it's, between others, oxygen necessary in high quantity at the site of an inflammation. The second half of the hyperemia, it's resulting this time from a passive process of compression of a vein. Being compressed, the venous end of the circulation, the blood is stagnating in the capillary bed, which is tributary for the affected vein. And as a result, we have in English it's called passive congestion. Another equivalent name is venous hyperemia, but we prefer here in Romania to call it stasis. All these are equivalent: passive congestion, venous hyperemia, or stasis. And it's the result of a compression, of an obliteration of the lumina of a vein. The result, accumulating blood in the capillary. This blood here, by contrary, opposite with the congestion itself, the active congestion, it's this time rich in carbon dioxide and not in oxygen, which means that the nearby cells will also suffer from certain, at least some degree of hypoxia, because of this accumulation, stagnation of carbon dioxide at the site of interstitial fluids. We can have a classification of this stasis according with the location of the occlusion of the vein. If it's a isolated small vein occluded, we call this as local stasis. If it's a much larger vein occluded, we call this situation as a regional stasis. These large veins, which are possible to be occluded, generating regional stasis, being the superior cava vein, the inferior cava vein, and the portal vein. There are, as a consequence of this regional stasis, resulting syndromes called superior cava vein syndrome, inferior cava vein syndrome, and portal hypertension. About superior cava vein and inferior cava vein syndromes, we are not discussing here at all. They are both of them extremely rare. About the clinical signs of these syndromes, you will learn in semiology, but we don't discuss about them in anatomic pathology. But we will discuss about portal hypertension because it's by far the most frequent type of regional stasis. And it's also possible to have a stasis affecting the entire body, which is called a systemic stasis, resulting from failure in the pump itself, the heart, or in cardiac failure. All these local, regional, or systemic stasis can start rapidly and have a short duration. And for such situation, they are called acute stasis. Or they can start slowly but last for a long period of time when it's called chronic stasis. It's possible for an initially acute stasis to be converted in a chronic one in time if the cause is not disappearing. So it's installed acutely, rapidly, severely even, and the cause remaining in place in time will become a chronic stasis. So not all chronic are necessary to start slowly. Some are the result of chronicization of a previously acute condition. Macroscopically, we have, as a result of accumulation of this rich in carbon dioxide blood, which have a much more bluish color than reddish color. So the result is a coloration in blue of the tissues which are available to be seen with naked eye, and this blue coloration is called cyanosis. Cyanosis is possible to be seen again at the level of skin or mucosas, and they are also by semiologists classified as peripheral and central type of cyanosis. With different significance, you can see in the text which are these differences. Because we can have this cyanosis resulting from stasis, so from a blood circulating condition, but also we can have cyanosis resulting from a respiratory insufficiency when the oxygenation of the blood by respiration is not good enough. So we have more than one condition which generates cyanosis. This is why it's necessary to have this more detailed subclassification. But anyhow, in both situations, central or peripheral, the affected tissue will turn in blue. And here we can see such cyanosis affecting the bed of the nails in a congenital heart malformation, both of these images being from my cases, obviously dead cases in Children's Hospital, but also the central type of cyanosis. It's seen mostly and the best being seen at the level of the lips, but having also this significance in some situation of respiratory insufficiency and some other of circulatory insufficiency. Microscopically, the same as it was in the case of hyperemia, the active hyperemia or congestion, we have the same thing, meaning capillary dilatation full with blood. Because it's impossible at microscopic level to make any difference between stasis and congestion, the English literature don't make the separation. Because at microscopic level, it's absolutely the same. As I said, from theory, the blood in stasis, it's a venous type, rich in carbon dioxide. In congestion, it's an arterial blood, rich in oxygen, but this is not possible to be seen in microscopic colorations, stains. So from this point of view, they are absolutely the same. This is why English literature don't make the difference between these two conditions. Again, if the cause is disappearing, the stasis will disappear without consequence at all. Again, like in congestion, if it's lasting for a long period, becoming chronic, an edema and microhemorrhages will appear for the same reasons, because of higher pressure in the capillaries, with a leak of more fluid than normal outside and edema appearance, and also by dilatation, gaps between endothelial cells, and leakage of red blood cells outside, so microhemorrhages. But supplementary, in this situation, the cells in the affected area, some of them will suffer from the oxygen diminution, and some of them, which are more sensitive to the presence of oxygen, will die. And those will be replaced by another tissue, which is by far the most resistant tissue to absence of oxygen, and this tissue is the connective tissue. This tissue is very resistant to very low oxygen level, because the connective tissue is made by very few cells. The fibrocytes are very few, otherwise disposed in a matrix of collagen fibers, which are fibers, are proteins, and don't need oxygen for their existence. Only cells need, and the number of cells in a connective tissue is very, very low. So for this reason, connective tissue is by far the most resistant to absence of oxygen. And this is why the damage, the necrotic cells which are dying in the long duration stasis inside an organ, will be replaced with fibrosis in time, slowly but surely. Now we start with the local or peripheral stasis, resulting from occlusion of a local peripheral vein. This occlusion is possible to be made in different mechanisms. For example, it's possible to have a thrombosis inside the lumina of the vein. By thrombosis, we'll understand coagulation of blood in the lumina of a vessel, a vein in this situation. Obviously, such a thrombosis will occlude entirely the lumina and will block the blood flow, and stasis will result from it. Another possibility is to have a thickening of the wall of a vein. This thickening will not occlude entirely the lumina, but the lumina will become smaller because of this thicker walls. And this thickening, it's happening in an inflammation of the walls of the veins, which is called phlebitis. Phlebitis and thrombosis are very frequently coming together, starting as a phlebitis and evolving with thrombosis in very short time after that. And this condition, combined condition, is called thrombophlebitis. And we have here such a image of a deep vein thrombophlebitis of the leg, which we'll see again this image later, generate lethality in a very particular way, but we'll understand this better later in the next lecture. The liver is an organ which can be affected by local stasis in an acute and in a chronic way. So both are possible. The acute means install rapidly but short in duration. Chronic meaning install slowly but very long in duration. In general in medicine, when we pronounce the word chronic, by definition this means that we have a condition, a disease, which is evolving for more than 6 months. This is the general definition for a chronic condition, more than 6 months. But in practice, we'll have a lot of exceptions from this definition. So a lot of other conditions which are lasting but not so much will be also called as chronic. And in some other situation, an inflammation can be called as chronic from the beginning, from the first day of evolution. So we have exceptions from this general rule, but as a general rule, we said that chronic means more than 6 months of evolution. In the acute stasis of the liver, obviously, the liver will become larger and a little bit more bluish in color as a result of accumulation of venous blood inside the liver. At microscopic level, we'll see the capillaries, the sinusoid capillaries, dilated and full with blood, as we already discussed as a general condition in any tissue, but here applied for the liver. So this is the acute stasis. Very nice image. This one, and it is coming from one of my cases. Each time when I have a better image than what I can find on internet, I am putting my images, even if it's not necessarily better, but at least of the same quality of what I can find on internet, I am putting my images. But some other images are from internet, if they are better than what I have, or if they are images that I don't have it at all. So the lecture and the practical labs will be illustrated with such images, some from our practical experience, some from others from internet. In the chronic liver stasis, this condition is staying there for more than 6 months. And as a result of this chronic long duration stasis, the cells surrounding the veins of the liver, and this most small veins inside the liver are the centrolobular veins. So here it's stagnating the blood. The cells surrounding this centrolobular region will start to die and to be replaced in time with connective tissue. This replacement, it's very, very slow. It's necessarily a lot of time to happen such a thing, meaning for the chronic liver stasis to last more than 10 years to obtain this replacement of part of the liver with connective tissue. And this replacement is called liver cirrhosis. So we can have a very particular type of liver cirrhosis resulting from chronic liver stasis. This stasis, chronic one, long duration, is resulting from heart failure. So it's part of the heart failure. And because this heart failure is generating liver cirrhosis in time, as I said, it's very long time necessary to appear such a thing. This liver cirrhosis is called heart-related liver cirrhosis. At macroscopic level, we have this aspect for the chronic stasis of the liver, meaning the color on section surfaces of the liver, it's not anymore brown homogeneous. Some parts of the liver remain with the normal brown color, and these parts correspond microscopically to the hepatocytes surrounding the portal tract. In the portal tract, we have the hepatic artery branches, which is bringing oxygen. And for this reason, the nearby hepatocytes surrounding the portal space, hepatocytes are not affected by hypoxia, so they remain normal in looking macroscopically, meaning they are brown. The centrolobular part of the liver surrounding the centrolobular vein are dying because of hypoxia, because here the stasis is the most prominent. And between this central lobular area and the periportal area, we have an intermedium area of hepatocytes. These hepatocytes located here are suffering from hypoxia, but not strong enough to die. They are adapting, in fact, to the condition of low oxygen availability. And this adaptation is made by switching the metabolism of the cell from aerobic respiration to anaerobic respiration. This is possible, at least in some degree, for these cells. And this switch will maintain them alive, but have a consequence, this switch. The anaerobic respiration, it's an activation of Krebs cycle if you are remembering about it from biochemistry. And as a result of this activation of Krebs cycle, energy is produced without oxygen, but as a result, in the liver cells is accumulating fat. This accumulation of fat is giving to these affected cells a yellow color. So for this reason, we have this alternation of normal looking brown color with much yellowish colors areas, which are the hepatocytes with fatty dystrophy, which are in fact hepatocytes suffering from hypoxia, but being adapted to it and not dying from it, at least not for the moment. This alternance of colors is also seen in a nut, a tropical nut. And British Empire, who was very extended, having a lot of tropical area in their composition, the Britons make the first, when they describe this chronic liver stasis, they make the comparison of this liver with the nutmeg. This nutmeg liver entered in this way in the English literature, but we in Romania prefer, because we are not at all familiar with this nutmeg. I never see it, just in images, in books. We prefer to call this condition as spotty liver. French literature describe this alternance of color as cocarde, foie cocarde. So different countries, different literatures are describing differently this aspect, but in all they make a reference to this alternance of colors. Microscopically, and I will better describe on image, we have portal tracts here with the portal vein, with the hepatic artery nearby, with biliary tracts inside, so portal spaces, and the centrolobular vein. From portal space to centrolobular vein, we have the sinusoid capillaries. In the center, we have stasis. We can see accumulation of blood, red blood cells here. And because of long duration of the stasis, the nearby hepatocytes are dead. The hepatocytes surrounding the portal spaces are absolutely normal. But in between, in this all intermedia, the hepatocytes are suffering from fatty dystrophy. This means accumulation of fat, which in histologic preparation is dissolved, so they will appear as clear vacuolar spaces in the cytoplasma of hepatocytes. Macroscopically, this area is yellow, this area is brown, and this central area, very, very small, but sometimes possible to be seen with naked eye, will be blue because it's full with venous blood. Here in even smaller magnification, these unaffected areas, these necrotic areas in the centers, which will in time be replaced with fibrosis, generating liver cirrhosis secondary for the chronic stasis. So here is the explanation of why fatty dystrophy is happening. We learn about fatty dystrophy in the chapter about metabolic disorders later with much more details. For the moment, only that is the result of anaerobic respiration. And here on a higher magnification, the stasis to the central zone of the lobule and the vacuolar cavities in the cytoplasma of hepatocytes in this intermediate zone, which is suffering from fatty dystrophy in chronic liver stasis. At the end, fibrosis here in a trichromosome stain, which is a stain specially made for connective fibers for collagen. We can see this collagen accumulating and surrounding nodules of remaining hepatocytes, and this disturbance of the normal architecture with replacement with connective tissue is called cirrhosis. Cardiac cirrhosis in this situation. The lungs are also an organ in which stasis can appear acutely and chronically. In the acute stasis of the lung, mostly as a result of acutely installed cardiac insufficiency after an acute myocardial infarction, the affected lungs are enlarged, so bigger, and very blue. Obviously, it's us during autopsy that we see this modification happening. These large and blue lungs, if they are cut during the autopsy, from them will be drained out very high quantity of very violet or blue blood because it's stagnating in large quantity inside the lung. Microscopically, the same, meaning the capillary are dilated, full with blood in the walls of the alveolar spaces. And even it's possible to have microhemorrhages in the alveolar spaces or edema seen in some alveolar spaces as a result of this stagnation of blood in the capillary with dilatation and hyperpermeability of these capillaries. In the chronic pulmonary stasis, usually it's again resulting from chronic, this time, cardiac condition, which is by far most frequently represented by mitral stenosis. Why is this happening? This is the heart, the septum, the left part of the heart with pulmonary veins being drained inside the left atrial cavity, the mitral valve here, and this is the left ventricle. And in mitral stenosis, the lumina of the mitral valve is progressively smaller and smaller and smaller. As a result, the blood will stagnate in the left atrial cavity and also in the pulmonary veins, which are drained here. And the pulmonary veins are draining from the lung, so also the blood will stagnate here in the lung, generating a chronic pulmonary stasis. More severe the mitral stenosis, more severe the chronic pulmonary stasis, and it is a progressive condition in time. A chronic heart failure will generate the same result. Macroscopically, this lung, chronically affected by stasis, will be described as brown induration of the lung. And microscopically, will have a very particular aspect, and we better see and explain this on images. Comparing with the normal lung, the chronic stasis in the lung generate, first of all, fibrosis. As we already described it in general part about stasis, long duration meaning hypoxia, hypoxia meaning death of some cells and replacement of them with connective tissue. This will make the lung, which normally have a consistency on palpation, which have a spongy consistency, will become much harder on palpation. Obviously at autopsic examination, because only then we make a palpation of the lung. And this is described by us as a hardening or induration of the lung. Also, in the alveolar spaces, as we saw already from the acute moment, small hemorrhages are taking place in the alveolar space. These red blood cells leaked in the alveolar space are removed by the local macrophages. These local macrophages are the alveolocytes type 2, meaning some of the cells covering the alveolar space, which are macrophagic cells, and this is why they are there, to remove any foreign body, strange body from the alveolar space and to make the local cleaning. In this situation, they will engulf, phagocytate the red blood cells and will digest these red blood cells. The hemoglobin from these red blood cells being digested, it's transformed by these macrophages in a brown pigment called hemosiderin. And this hemosiderin in chronic pulmonary stasis is accumulating in the lung together with the fibrosis, and the result will be a brown induration of the lung. This is why it's called like that. So the lung is larger a little bit, harder on palpation, and much browner in color than normal. And this is how it looks at microscopic level. Very, very nice image, otherwise it's not mine. The alveolar space full with macrophages, which in their cytoplasma contain this brown pigment, which is the hemosiderin, and this is generating the brown color of the lung. Also in the septum, which is normally very, very thin septum of the alveolar space, connective tissue start to develop, enlarging and hardening in this way the consistency of the lung, but also interfering in this way, this connective tissue, with the normal oxygenation of the blood in the lung. So this chronic pulmonary stasis in time is generating pulmonary insufficiency, respiratory insufficiency, because it is by this fibrosis development interfering with the normal oxygenation of. So in long duration, mitral stenosis, not operated, it's possible to develop in time and to die from respiratory insufficiency, in fact. The regional stasis or passive congestion this time meaning the superior and inferior cava vein. I put here some images with this dilatation of jugular veins for the superior cava vein syndrome, this dilatation of lateral abdominal veins in inferior cava vein syndrome. But we are not discussing at all, both of them being the result of occlusion by usually thrombosis of this very important large vein, which are the superior cava and inferior cava vein. But they are both of them extremely rare in practice. By far the most frequent regional stasis is the stasis of the portal vein. It's necessary to remember from anatomy that the portal vein, this is the one, it's in fact the result of conjunction between the inferior mesenteric vein, superior mesenteric vein, and the splenic vein. Also, in the portal vein, it's drained the stomach, the gastric veins. In their time, they are draining also the veins from the level of the inferior segment of the esophagus. So all this territory, it's tributary to the portal vein. When it is occluded, all the territory is affected by stasis. The stomach, the inferior esophagus, the lower mesenteric vein, it's draining the large bowel. Superior mesenteric vein is draining the small bowel. Splenic vein, obviously, it's draining the spleen. So all the entire abdominal cavity will be affected by stasis, a chronic one, as a result of occlusion of the portal vein. This occlusion of the portal vein, which is generating a higher pressure in this entire territory, it's called also portal hypertension for this reason, and most clinicians are referring to this condition in this way. For us, it's the same chronic portal stasis or portal hypertension, but clinicians prefer the terminology of portal hypertension. By far, the most frequent cause of occlusion for portal vein is, in fact, the liver cirrhosis. And the liver cirrhosis, it's very frequent, of a lot of etiologies, from alcohol consumption, chronic alcohol consumption, to chronic hepatitis of different etiologies, toxics, medications, a lot of etiology, and liver cirrhosis is very, very frequent. And for this reason, also portal hypertension is very, very frequent. And this is because the portal vein is entering in the liver, and if the liver is destroyed by cirrhosis, this entering is not possible anymore, or at least not as it used to be normally. So it's a diminishing in blood flow inside the liver because of this liver destruction in cirrhosis. But it's not the only cause for portal hypertension. It's much more rare. More than 95% of portal hypertension are caused by liver cirrhosis, but the remaining 5% is possible to result from portal vein thrombosis, portal vein phlebitis, meaning inflammation of the wall of this portal vein, or a combination of both of them, meaning portal vein thrombophlebitis, or also is possible from an outside compression. It was also the case for the local veins too. Outside compression is a possible cause because veins are having a quite thin wall. They have a muscular wall, but it's thin. Very easy to be compressed from outside by a nearby tumoral process. And this nearby tumoral process here, most frequently behind the stomach, we have the pancreas, the head of the pancreas more exactly. It's quite frequently the site of malignant growth of tumor, and in this growth, this malignant tumor can eventually compress the portal vein and to generate the portal hypertension as a result. But it's comparing with liver cirrhosis rare. This is how it looks, the liver cirrhosis. The entire organ, liver, is transformed in nodules surrounded by connective tissue, and these nodules are compressing the portal tracts, the smaller ones and the larger ones. And by this compression of these nodules, which are called regenerative nodules, the lumina is diminished for the portal vein, and by this occlusion, the normal transition, the normal circulation of the blood, it's diminished, and the portal hypertension will appear as a result. Here we have a portal vein thrombosis as an image, not mine. But here it's one of mine images from, I remember very well, a case of a girl, 14-year-old, who died with a hepatocarcinoma, meaning a cancer of the liver. This cancer generated metastasis in the nearby lymph nodes, which lymph nodes became enlarged, compressing the entrance in the hilum of the liver of portal vein, and generate a certain degree of portal hypertension. She didn't die because of portal hypertension. She died because of this liver cancer, but also had some degree of portal hypertension as a result of this outside compression. We'll see again this image later when we'll discuss about tumors, because this case have much more interesting history than what you can see and hear now. The portal hypertension means stasis in the territory of the portal vein, meaning that we have stasis in the splenic vein. As a result of this stasis, the spleen will become enlarged, meaning splenomegaly. So splenomegaly, it's one of the portal hypertension syndrome. Syndrome being, we understand by syndrome, collections of more than one symptom. Splenomegaly is one symptom from the more complex accumulation of symptoms in the syndrome. The other two branches, the inferior and superior mesenteric vein, are draining, as I said, from the intestinal tract the blood. By stasis here in these branches, the pressure in the capillaries will be higher in the wall of the intestinal tract. And as a result of this, an edema, meaning leaking of serum from blood outside in the interstitium, will take place in the wall of the intestinal tract, and from the wall of the intestinal tract in the peritoneal cavity. And as a result of this stasis in the superior and inferior mesenteric vein, liquid will accumulate in the peritoneal cavity with the name of ascites. But despite this situation, somehow the blood still needs to circulate. If it's not possible anymore to circulate passing the liver from portal vein to superior hepatic veins, the blood will find other ways to circulate. And these ways are called collateral circulation. And it is possible because normally, physiologically, we have certain territories in our body in which the territory tributary to the portal vein is connected physically by anastomosis with the other veins which are tributary to the inferior cava vein. And these territories are the inferior segment of the esophagus, the rectal segment of the digestive tract, and the skin surrounding the umbilicus. So at these levels, the local veins will become dilated with high pressure inside, and at least part of this high pressure blood accumulating here because of stasis in the portal territory will enter in back to the inferior cava vein and will continue to circulate. But the result will be dilatation of these veins here located, and this dilatation of veins are called varix. So we'll have esophageal varix in the lower third of the esophagus, rectal varix or hemorrhoids, and dilatation of the vein in the periumbilical location, which is called in all literature of all languages as caput medusae. So these are three other symptoms coming together with ascites and splenomegaly, and all together are forming the syndrome. Because otherwise we can have splenomegaly for other reasons isolated. We can have hemorrhoids for other reasons isolated. We can have ascites from other reasons isolated. When they are isolated and not together, they are not portal hypertension syndromes. So only together they form the syndrome. Here an image, otherwise one of mine again, to see how large can become the spleen comparing with the cirrhotic liver nearby. The liver with cirrhosis is nodular, as we can see, and the spleen is even bigger than the liver itself in the splenomegaly process, part of the portal hypertension. Here, the accumulation of the liquid in the peritoneal cavity, seen here at autopsy, not from the same patients, but from different patients, but to see how it looks. It's a little bit, it's transparent but yellowish liquid accumulating inside the peritoneal cavity in large quantity, more than 1 or even 2 or even more than 2 liters in the peritoneal cavity. This accumulation generates this enlargement of the abdominal cavity, which is very, very impressive. In this image taken from internet, because otherwise the previous 2 images was from our cases here in Cluj. This is one from a book, just to impress, because otherwise it's the same enlargement of the abdominal cavity with which is full with liquid. But also this woman had an umbilical hernia, and this hernial sac also became full with this liquid accumulated in the peritoneal cavity, becoming even more impressive. These are the territories where the cava vein territory is connected with the not the portal vein territory, it's connected with the cava vein. The lower segment of the esophagus, the rectal zone, and the periumbilical zone. And here are the images for caput medusae, both of them. This one obviously more severe than this one. This is a symptom which is not very frequently seen. In fact, they should be present to all cases with portal hypertension, but not always very obvious clinically. The esophageal varix are the best way to see them are endoscopically during life, but also for us after autopsy we can see these remaining dilated veins at this distal segment of the esophagus, and also the same dilatation of vein at the level of rectum, the hemorrhoids. Here it's one of mine images of the esophagus with dilated vein, very well seen beneath the surface of the mucosa, but not broken, because this dilatation of the varix of the esophagus can eventually evolve to a breakage of this varix, and with very severe, very frequently lethal hemorrhage resulting from this breakage of this vein. But in this case, it was not broken. But it was, in this case, also one of my cases. Again, girl 17 with liver cirrhosis. You can see here the nodules in the liver, and with a lot of blood in the lower segment of the esophagus because she suffered from such a rupture of the esophageal varix, which was, in fact, the cause of death in this situation. To correct this portal hypertension, surgically, in theory at least, it's possible to make a surgical shunt between the splenic vein and the renal vein, which is beneath. The renal, obviously the left renal vein, it's parallel with the splenic vein, so a connection normally not present, it's possible to make between them surgically, and in this way to relieve the tension inside the portal system. Unfortunately, this type of intervention in patients which already have liver cirrhosis is with very high risk of lethality, and for this reason it's made practically quite exceptionally. So it's not something made by routine. Most of patients having portal hypertension evolving naturally and dying at the end, or because of rupture of the esophageal varix, 40% of them are dying in this way, or the rest, the 60% rest, is dying because of liver insufficiency. So they are very rarely treated in this way with a portocav surgical shuntus. Also, these shuntus, unfortunately, when they are done, are very frequently thrombosed. So at the end of this thrombosis, the entire shuntus was made for nothing. Liver transplantation is the only real solution for those with liver cirrhosis for surviving. The systemic stasis is resulting from the failure of the pump of the heart itself. It's called congestive heart disease when the entire heart is suffering, mostly because of myocardial infarction. Or it's possible to have only a right heart failure, so only the right part of the heart to suffer failure, but enough to generate a systemic stasis. The consequence of this will appearing of a generalized edema. Edema affecting all tissue, all organs, with including ascites, accumulation of liquid in the thoracic cavity, in the pleural cavity under the name of hydrothorax, including with accumulating of liquid in the pericardial cavity under the name of hydropericardium. The generalized edema with hydrothorax, ascites, and hydropericardium all together when it's happening, it's called anasarca, or the extreme generalized edema. Now we finish with hyperemia, and we'll continue with another topic, which is the opposite of hyperemia, and it's called ischemia. And by definition, meaning a diminution of quantity of blood in a certain capillary territory. And this diminution is possible by only one mechanism, meaning by occlusion, partial or total occlusion of the arterial blood supply of the territory. So the causes here will be at the level of the arterial side of circulation and not on the venous side, as it was for the passive hyperemia or stasis. Obviously, to have less blood in a certain territory of capillary, it's possible to be the result of a very massive hemorrhage, or by causes affecting the artery itself. If this is the artery, we can have inside the lumina occlusion resulting from coagulation of blood. This is called thrombosis. Or occlusion with thrombus coming from other regions of the circulatory bed, which is called embolia. We'll learn separately about both of them in the next lecture. Another cause can be in the wall of the artery, which can become more thickened, narrowing the lumina in this way, because again of an inflammation of the wall of the artery called arteritis, or even much more frequently, in fact the most frequent cause for ischemia is the atherosclerosis, meaning accumulation as a plaque in the wall of the artery of cholesterol. And this is narrowing more and more the lumina, occluding gradually but surely the lumina of the artery with accumulation of cholesterol here, and this is the atherosclerosis. Much more rare but possible eventually for the lumina of an artery to be occluded by spasm, meaning an active contraction of the muscular wall of the artery. All of them can produce obliteration, complete or partial obliteration of the lumina, and to generate ischemia. And as it was for the veins too, outside compression it's also possible to be involved. Much rarer than for vein, but it's still possible by usually a nearby tumoral process. Macroscopically, the organ or tissue, it's without blood inside in ischemia. And for this reason, the organ is very pale in color. And if it's long enough in duration, this ischemia will also generate the necrosis or the death of that tissue without blood, without oxygen, the tissue cannot resist for a very long time. Here in the image, a very otherwise nice image from one of our cases. It's the liver with nodules on the surface, very thin but present nodules, meaning liver cirrhosis, but extremely pale, this liver, because the patient died with massive hemorrhage resulting from rupture of esophageal varix. And because of this massive hemorrhage, all the organ, but in this image only we see the liver, were depleted from blood. Without blood remaining, the entire body became very, very pale. At microscopic level, what we see, it's varying with the time. Meaning if very rapidly happened, the ischemia, and the patient died, like in this situation, we'll see nothing. So without oxygen, tissues, all the tissue, especially the brain, is dying very rapidly, but not having time to make microscopic changes. Everything is very rapid. In other situations, we can see the dystrophy, the fatty dystrophy we already discussed, because in the condition of ischemia or shortage in oxygen, some tissues will adapt with anaerobic respiration developing inside fatty dystrophy. So sometimes we will see this fatty dystrophy, and some other times, if the evolution is severe but quite slow, we'll see the cells of the organ dead with necrosis. Now another topic to discuss about, the last for this lecture, the hemorrhages. They are defined as an extravasation of blood from the vessel to the extravascular space during life. This during life is important because when we cut during autopsy the organs, obviously the blood is flowing out from these organs, and this is not an hemorrhage because it's happening after death. Only during life, when it's happening such a leakage of blood outside from blood vessels, it's called hemorrhage. As a mechanism for hemorrhage, obviously the most obvious cause is a rupture of the blood vessel wall. This rupture can be after a trauma of any kind, from car accidents, any other accidents, to bullets, stabbing, anything which traumatically interrupt the continuity of the wall of a vessel, artery, or vein will generate an hemorrhage. But we can also have spontaneous ruptures of blood vessel, especially of arterial vessel, when the pressure inside, the pressure of the blood, became very, very high. This condition is called hypertension, more exactly a crisis of hypertension, because hypertension meaning having pressure in the blood vessel higher than normal, but in crisis, when appear, it's very, very big, this pressure, and in this particular moment it's possible to have ruptures with hemorrhages. These hemorrhages are possible to appear anywhere in such background of hypertension crisis, but most frequently sites are in the arteries of the nasal cavity, with extravasation of blood of the hemorrhage in the nasal cavity outside under the name of epistaxis. It's the happy version, or the worst version, but it's also unfortunately quite frequent to have a rupture of artery inside the cranial cavity, most frequently inside the brain itself, generating a stroke, which is very frequently lethal. Without hypertension this time, it's possible to have the same rupture of an intracranial artery, generating the same stroke as in the first situation, but this time because of a congenital malformation of such an artery inside the skull, the cranial cavity. It's called congenital berry aneurysm, this malformation, and consists in the congenital absence of just one or two muscular cells focally from the wall of the artery. So it's a very localized anomaly with absence of one or two cells, nothing more, but enough to make that spot a weak spot, which will evolve from birth or even before with a dilatation of the arterial wall at the site of this malformation. And this dilatation is called an aneurysm. Being from birth, it's congenital. And in English literature, it's also called berry aneurysm, this congenital form. Because they are also possible to be non-congenital, to be acquired, and then they are not berry aneurysm. In such situation, having a congenital berry aneurysm, the child, it's completely asymptomatic, don't have any symptomatology at all. He has a very normal childhood evolution, and the rupture usually appear later during young adulthood age or during teenage. Because of high intense effort, sport effort usually, which is starting usually to be made at these young ages. And during an effort, the intravascular pressure for a short period of time it's high enough to generate a spontaneous rupture for such a congenital berry aneurysm and to produce stroke and lethality very frequently without having no symptoms at all before that accident. Fortunately, it's a rare event, but possible. Any sudden death, not for small infants, but for young adults during a sport activity. Sometimes this sport activity can be sexual activity even. So during such an activity, it's first of all a suspicion that the patient had such a congenital berry aneurysm. There are other causes too possible, but this is by far the first one to be taken in consideration, despite the fact that fortunately it's quite rare, this type of anomaly. Another type of spontaneous rupture can happen at the level of the heart itself. After a myocardial infarction, it's not needed to die immediately. The death part of the heart after myocardial infarction, after 2 or 3 days, not more, it's eventually possible to suffer a spontaneous rupture. As a result, the blood from the heart will extravagate outside in the pericardial cavity. It's called hemopericardium, this hemorrhage. And as a result of blood accumulation in the pericardial cavity, the patient is dying suddenly. But he is not dying because the loss of blood, because inside the pericardial cavity, it's only possible to enter about 600 to 700 milliliters of blood, not more. You can donate such amount of blood without happening anything. So it's not the volume itself, the loss of this volume of blood which is killing. It's something else. And this something else is called tamponade. This is happening because any liquid, including the blood, it's an uncompressible environment. Any liquid of any kind, water, oils, any liquid. And being uncompressible and accumulating in the pericardial cavity, when the heart is contracting in systole, it's becoming small. And in systole, by contraction, the blood is expulsated in the pericardial cavity. And after that, in the diastole, by relaxation, the heart should become larger, but cannot dilate, cannot relax at all, because it is surrounded by an uncompressible liquid. So the patient will die with the heart being stopped in the systolic part of his activity. And this is the tamponade. So cardiac tamponade is a mechanism. Otherwise, the accumulation of blood here in the pericardial cavity being called hemopericardium. Here we can see such hemorrhages on the surface of the brain beneath the dura mater. It's called subdural hematomas. It's a site where hemorrhages, when appear, compress the brain, and it's possible to kill in this way by this compression. If it's not diagnosed very rapidly and remove this hemorrhage by neurosurgery. When we see such a thing, the books are telling us that in 99.9% of cases with subdural hematoma, the cause is a traumatic one. And being in this way traumatic, we stop from our autopsy, because normally we as anatomopathologists, we are performing autopsies only in patients who are dying from medical conditions in hospital. Despite the fact that such a patient died in hospital, having a traumatic cause, the autopsy should be made and an enquete of the case being made by forensic legal medicine. So we transfer the case. If we find such a thing that in our autopsy, we are transferring the case to the legal medicine, to the forensics, because it's their job to take such post-traumatic, because it's always a suspicion of a possible crime eventually. It's possible to be an accident, but also possible to be a crime, so it should be investigated. When the hemorrhage is inside the brain, it's called the brain hematoma, resulting from hypertension or barium aneurysm, as I said. Once the blood is entering in direct contact with the cerebral tissue, the chemical composition of the blood is irritating the tissue. And this irritation will generate excitation of all neurons at once in the entire brain. and this makes the brain unable to function, and this is why the symptom is a coma. So in the very moment when direct contact between blood and cerebral tissue is made, the patient is entering rapidly in a coma and he's losing any contact with the surroundings. He's in a very deep sleep. He even don't have pains at all. He's just in a coma. Regaining the normal activity of the brain is possible only if the neurosurgeon will be able to remove this quantity of blood. If the neurosurgeon cannot do it, the patient will die because of this hemorrhage. The diagnosis is made quite easy on computer tomograph of such hemorrhages to see exactly where it is, the location of the hemorrhage. Sometimes the pressure inside the hematoma is so high because it's a crisis, a hypertension crisis, then the cerebral tissue is dissected by hematoma and the blood is invading the ventricular system. When such a thing is happening, the contact between brain and blood is even higher on a larger surface, and the surgeon will be not able to operate such a thing for nothing in the world. So such cases, when the computer tomograph it's seeing that we have a hematoma with invasion in the ventricular system, the patient, it's not anymore possible to do anything for them, and they will die in coma being already in just a few hours. From the ventricular system, the blood is circulating with the cerebrospinal fluid, and it's possible to be found and seen at autopsy even on the surface of the brain, because here we also have contaminated with blood cerebral fluid. Here is the heart with rupture, surrounded by a large quantity of coagulated blood in a hemopericardium. Here the same image, but with pericardium opened and seeing only the blood covering the heart. The dying mechanism here being the tamponade, as I said. Another cause for hemorrhage is not a rupture of the wall of the blood vessel, but an erosion, but by a pathologic process evolving in the surroundings. By far the most frequent and easy to understand process who erodate the wall of vessels is the gastroduodenal peptic ulcer. As a result of this erosion, gastric hemorrhages result, and it is by far the most frequent complication of a gastric ulcer. Same thing is happening in the lungs too, in the developing and evolution of cavities or caverns generated by tuberculosis. They also can erode blood vessels, generating lung hemorrhages. Atherosclerosis, arthritis, or infection of the arteries can also generate, this time not berry aneurysm, but what is called mycotic aneurysm, which also have the same susceptibility to break spontaneously and to generate hemorrhages. This mycotic aneurysm is appearing as a complication for septicemia, meaning circulation of bacteria in the blood, and this bacteria will infect the wall of the artery, focally destroying a few muscular cells, and as a result, the appearance of aneurysm. It's called mycotic despite the fact that the etiology is microbial, because the aneurysm, this mycotic one, look like a mushroom. This macroscopic appearance also been seen on arteriographic examination. It's generating the name of mycotic aneurysm. Just it look like a mushroom, but it's not mycotic in etiology. It's bacteria. Also tumors, malignant one, the cancer, as we'll see at the end of this semester, when they grow by infiltrating and destroying the nearby tissue, including blood vessels. And for this reason, malignant tumor have characteristically for them hemorrhages inside. Here it's such an ulcer, gastric ulcer, with hemorrhage at the bottom of the ulcer itself. Here are aneurysms, berry or congenital ones, both of them possible to suffer spontaneous ruptures. Here it's a cavity in the lung generated by tuberculosis who erodate such a vessel, generating a large hemorrhage inside the cavity. Here it's a malignant tumor of the kidney with hemorrhages inside. And we also can have hemorrhages, this time very small microscopic ones, resulting from hyperpermeability of the capillary vessels. They are not disrupted at all. They are still there, present, the wall, not ruptured in any way. But in acute hypoxia, in chronic long duration hyperemia, in both stasis and congestion, microhemorrhages can appear. In acute hypoxia, these hemorrhages are very particularly located, are small, very small ones, so it's the patient is not dying from this local, very superficial hemorrhages, are located on the surface of the pleura or of the pericardium, so only in this location. They are small quantities, but very well seen and described first by this guy called Tardieu, a French guy, who make autopsies for persons who were executed by hanging during French Revolution. And he saw, because they, by hanging execution, suffered of an acute hypoxia, they all develop such hemorrhages on the surface of pleura and pericardium. But other causes of acute hypoxia will also generate the same thing. For example, drowning, it's also generating the same result. And it's a very important sign for legal forensic medicine, because it's possible in this way to identify an acute hypoxia even if you don't see anything at the surface of the body. For example, if you want to suffocate somebody with a pillow, putting on his face, no signs of this asphyxiation will be seen on the surface, looking like a perfect crime. But any pathologist and forensic doctor know very well that spots of Tardieu will be present there and indicating the mechanism of that. Also possible to have such capillary bleedings when the coagulation factors in the blood are consumed or destroyed. Such a thing is happening in liver insufficiency, because the liver is the most important producer of coagulating factors in the blood, in leukemias, and in the disseminated intravascular coagulation, the same result. So in all these situations, diffuse capillary bleeding, multi-organic, can appear. These are the spots of Tardio in one of my cases. It was not a crime. This patient died, in fact, because of what is called pulmonary edema resulting from a cardiac insufficiency. Cardiac edema means that all alveolar spaces, or almost all, are full with a liquid extravagating from the blood vessel. The serum liquid, in fact, extravagating in the alveolar space, invading this alveolar space. In fact, the patients, and a lot of them are dying in this way, children or not children, drowned, being in their own liquid. So not from outside liquid, but their own liquid. Pulmonary edema generating very frequently lethality in this way, and being also macroscopically evolving with spots of Tardieu on the pleural surfaces, on the pericardial surface in this image. Purpura, cerebral purpura, are microhemorrhages inside the brain, and they result after hyperpermeabilization of the capillaries during inflammation, meaning a pathologic hyperemia of the brain. And this inflammation is called cerebritis or encephalitis. And here is the microscopic image for such a cerebral purpura, meaning we can see the red blood cells, a lot of them, but they are obviously not inside the lumina of a blood vessel, but outside in the cerebral tissue. This means that it's a hemorrhage, but it's so small that the entire hemorrhage, it's possible to be seen in one microscopic field. This is why it's called microhemorrhage, microscopic seen hemorrhages. But also as very small red spots possible to be seen with naked eye too. We have a classification of these hemorrhages according with the place of where the hemorrhage is produced. When it's produced on the surface of our body, it's called external hemorrhages. And these external can be arterial hemorrhages when the blood is obviously red with pulsative flow, or venous hemorrhages when the blood is obviously very dark brown or blue in color without pulsative flowing, but just flowing. Capillary hemorrhages, which are very small, dotted pattern, and cardiac hemorrhages possible too, eventually, after stabbing in the heart, for example. Exteriorized hemorrhages are hemorrhages happening somewhere inside the body, in a cavity which is connected with the surface by some channels. And not immediately, but in time, sooner or later, the hemorrhage in the cavity will be exteriorized outside. This exteriorization has different names according with the location. And we have listed here these names: epistaxis, otorrhagia, gingivorrhagia, stomatorrhagia, hematoptysia or hemoptysia, hematemesis, melena, rectorrhagia, hematuria, menorrhagia, metrorrhagia, for each of them having in the text also the definition. You can read it from the slide or from the book. Internal hemorrhages are inside the cavities or inside the organs of the body, but which are not connected with external surface, so they will not become apparent at all. These are the most dangerous one because they are quite difficult to be diagnosed, being related with much higher level of lethality because of this difficulty in diagnosis. In the serous cavities of our body, like pleural, pericardial, peritoneal cavity, the hemorrhages are here and listed with their name. Hemothorax, hemopericardium, we already discussed about it, hemoperitoneum, hematochele in the nearby the testicle, hemarthrosis in the articular cavity. But also can appear interstitially in the thickness of some organ under the name of hematomas. These hematomas, when they are very small, in evolution can be resorbed and to disappear, but only for the very small ones. When they are very large, they are not possible to be resorbed at all, and in such situation, the body will develop, surrounding the hematoma, a connective tissue capsule. And this development of a capsule is called enclosure. The capsule delimiting inside a cavity full with blood, which is usually destroyed in time, but still remaining as a blood. Sometimes these hematomas, enclosed or not yet enclosed, can be infected with microbes from nearby, and in this way the hematoma will be transformed in an abscess. For medium-sized hematomas, the formation of capsule, fibrous capsule, will continue with the fibrosis of the entire hematoma. So the result will be a scar. A scar rich in hemosiderin, which is brown in color, but still a scar replacing the medium-sized hematoma. When the loss of blood is with small quantity, less than 20% of the volume of the blood, it's of little impact, and it's possible to be regenerated quite rapidly, this loss of blood, with no importance at all in healthy persons. When it's higher, the level, than 20%, it's possible to develop an anemia, or even if it's very high, the loss, more than 50%, to develop what is called a hemorrhagic shock, which is possible if it's not very rapidly compensated by perfusion of liquids and blood from outside to generate lethality by exsanguination. And that's all for today, for this first lecture, and we'll continue from here this week during the practical lab. Bye-bye.